Hello and welcome to another episode of Diabetes Dialogue, Technology, Therapeutics, and Real World Perspectives. My name is Diana Isaacs. I am joined with my co host, Natalie Bellini. And in this episode, we have some very interesting news. So, hot off the press, the dual glucose ketone monitor has gotten CE mark. So, what that means is it will be approved in Europe, and we very much hope that the US will be next. Natalie, I'm going to turn it over to you to talk a little bit about what is this and what to expect.
Thanks, Diana. Welcome, everybody. We're so glad you're here. Uh, so let's talk a little bit about all things continuous ketone monitors. I think this came before I thought it would. I don't think I was ready for this. But let's talk about this. So Abbott announced today that it has secured this CE mark for two sensors, actually, the Libre Duo and the Libre Duo 10-day, the first dual ketone glucose monitor ever, right? This is pretty amazing. The system measure both glucose and ketones. So there was some question as to how these would look and what's going to happen. They're going to measure both in one sensor, which is amazing. Every minute through a signal wearable sensor, offering real-time visibility into a rising ketones that may signal risk for DKA, diabetic ketoacidosis. Abbott plans to launch the system in select European countries later this year. So I think what we need to know about this so far is that this is a major milestone in this CKM field, which is drawing more and more attention. So why do we have two of them, right? First of all, why do we have two? Because one is going to be for adults and one is going to be for children. The 15-day will be for adults, and then the 10-day will be for children. Why? Because children just eat sensors somehow. I don't know what happens. They have more failed sensors. They have more problems with sensors. They're more active. Their body parts move more, right? They're all over the place. And so when they did the trials, it made more sense and had more success when they did the 10-day on kids and the 15-day on adults. So that's number one, right? Number two, why do I feel so strongly about this? Because of SGLT2 inhibitors, right? We use them in people with type 2 diabetes, people with heart failure, people with kidney disease. And we have risk when we do it with people with type 1 diabetes because there's an increased risk of that euglycemic DKA. So I hold off in my practice going, okay, I've used the drugs I can use. I use finerenone. I use other things to help preserve kidney function. But there's always this, are they going to be the person that ends up in DKA or not? Well, if I put them on a continuous ketone monitor, I'll know if they're that person, right? So that's my big, let's go, let's do this kind of thing. Diana, how do you feel?
Yeah, I'm very excited. I agree with you. Like this is sooner than I thought, but of course, we want the US indication. Like that's what we want so we can access it for our patients. But I think this is really a revolutionary technology. The way people check ketones right now is very archaic. I mean, most are still doing urine because of the cost of the strips. And so it's just like this is needed, this is necessary, especially in type 1 diabetes. I think this will be the standard of care. It is interesting about the two different sensors, the 10 versus the 15 days. So I do worry a little bit just about the confusion with ordering. Hopefully it'll be pretty clear. Over 18 is going to be the 15-day. Under 18, you're going to use the 10-day version.
Which is
Um,
2 and up, by the way, which is pretty
yes.
miraculous, right? So you would think 8 and up, or you'd think 5 and up, because those littles are even harder, right? Their numbers bounce anyway. I'm thrilled that they got 2 and up as the indication.
Right, and then with, like, hopefully they'll, at launch, have the AID integration because that's a really great use case for it, because we just know infusion sets and just there can be an interruption in insulin more readily with people that are on pumps. So it's very exciting. I mean, I think questions remain about, well, is it gonna be the same cost? Is it gonna be a higher, I mean, I could see it being a higher cost because you're getting added value, right? And is it, are people gonna be able to pay that cost? Is insurance, or in Europe, is the national health plan gonna pay for it? So that those types of things will be really interesting, but hopefully we'll also start to get real world data, real world use from it. Because I think so far the published studies have been a little bit more limited. there's definitely some interesting things in terms of glucose levels and ketones. It's not a linear relationship. That's why we need this, because you can't assume, oh, someone's glucose is 300, now they have ketone. No, like someone could be sitting at 400 for hours and not have ketones, and another person could be 250 and have ketones. Like it's just not a linear relationship. That's why we really need this technology.
I absolutely agree. And so where would we start? We don't Everyone with diabetes, I don't think is going to need this. So, the it's people that I would think of, people with type 1, because if we
Mhm.
interrupt insulin at all, right? So if someone's on an insulin pump, even if it's an AID pump where the sensor's talking and they're controlling the glucose and they're doing this and they're doing that, they can end up in DKA faster than the average person who is still on MDI, because there's no 24-hour basal insulin going, right? So it's interrupted for whatever reason. Yeah, those soft catheters, they don't hurt. They don't hurt partially coming out for a lot of people. Then they don't realize it. They're not really paying attention because they're trying to live their life with diabetes. And all of a sudden, they're now nauseous and they're vomiting and they need a bag of fluids and they need to be treated in the ER, right? Can we avoid that? Can we avoid those admissions for people with type 1? That's number one. Number two, type 2 using an SGLT2 inhibitor. Maybe not forever, but at least to see if they're going to end up ketotic from it. And then, I could see myself going, okay, you develop some ketones. Let's even use them, but let's cut the smaller dose in half. Maybe I just use half the dose and see if we can get non-ketotic, numbers, and still use some of an SGLT2 inhibitor. And then people with recurrent DKA, that's another one where they just struggle. They just struggle with DKA. That's another group of people I could see using this in. Peds, because peds is just, I describe their glucoses. The younger they are, the more wonky they are. And that's a medical term, just wonky, right? They go from
Wonky.
40 to 400 and back again, and they're up and they're down and they're right. It's like little kids get really sick fast, but they get really well fast, right? So I could see the use in the pediatric population. And then people who are hospitalized with an elevated DKA risk because they're not eating for hours and hours, because they're doing so. If we're changing something and their medical management is changing, is that someplace where we would use them? So those are kind of like my top big groups as to where would we use this? What would we do with it? Who doesn't need it? Someone on metformin and a GLP-1, probably with type 2 diabetes, does not need like continuous ketone monitor, probably, right? And think about all the people who are going to say, I need a ketone monitor. I want to be in ketosis. I don't know that these people truly need to do this, right? Like anytime you miss enough calories for the day, you're going to have some ketones in the morning, right? Like, so I do believe that there will be people pushing it for, I want to be on a ketogenic diet. I want to do whatever. But my goal is to get them to the right people at the right time. And that's really those groups of people I think would benefit the most right away.
Yeah, I agree that definitely those groups would benefit, and if we have to prioritize, those should be who get it. I guess though, if cost wasn't an issue and it's supposed to be the same size as a Libre 3
Yep.
Plus, and if it's just recording one additional analyte, I don't think I'd have a problem if everyone wanted to use it. The analogy I think of is my Apple Watch and my phone record all kinds of information. One of my patients today was telling me, I was asking him about his sleep, and he's telling me, oh, well, my sleep score is 89. It could be better. And then so I go look at my sleep score. I'm like in the 60s. I didn't even know my phone was calculating my
Watching
sleep
you. Right.
score.
Yeah. Right.
So it's kind of like, well, if you don't need the information, you might not look at it. So I could make a case that, why not have it? I don't think it would hurt. Some of the questions I still have, though, I wonder, like for kids, would they be willing to switch if they're on a 15-day, whether it's the Dexcom 15-day or it's the Libre 15-day? Are they going to want to switch to a 10-day sensor? I mean, some might, some like their skin to refresh, and not wear something as long, but other people don't want to have to do as many insertions. The other question I have is, would this make people want to switch from Dexcom to Libre, knowing that Libre is the first to have the ketone ability? So it'll be very interesting.
It's going to be very interesting. And of course, more to come. Hopefully, we'll get to see and talk to people when we're at ADA about this next week.
Definitely. And so kind of speaking along those lines, there was some really interesting news with Dexcom this week as well, that apparently there are certain lots that they decide to scrap because they kind of in their quality process, they figure out they're not meeting the standard. So they're going to scrap them and they're not going to give them out to the public, right? So they had the trucks of scrapped sensors that got stolen. And then now they're in the market and they've been sold. I guess they've been bought by third party payers or third parties. And so they're just out there and people unfortunately could be wearing them. Now Dexcom has let us know, and we know there's 2 lots that are affected that people can go and check, but like what craziness. It's
I
like
don't so I couldn't make this up if I tried, right? Like
right?
someone stole a truck full of sensors, and the concern, to be honest, is not just inaccuracies, but they were pulled from a line, so some of them are not sterile, right? So it's even
Oh,
bigger
yeah.
than, right? That's part of the risk. So
Yeah.
they haven't been through full quality because they were pulled from the line. This is what happens. This is what quality improvement is about, is saying, wait a minute, we don't like the looks of this, pull the entire lot, throw them away, and in that throwaway process, someone took them, right? There we will, yeah, there's 2 lots that I think have been affected that I've heard about so far, but I don't know how many that means, or we're kind of waiting to hear the rest of the story from Dexcom. So as we hear, we'll get back on and fill you guys in a little bit more about it. But people should go online. You as a clinician should go online, figure out the lots, and make sure as you're seeing people to double check that they're not affected by those lots. And hopefully we'll know more. You know, Libre had a recall last year, was it late last year maybe? And when you scan the Libre to start the sensor, it would say right away, you can't use this one. Contact customer support. So I'm hoping that Dexcom will set something up like that. You know, the only challenge with that is if they're using a reader, the readers aren't talking to a cloud. So we still have a risk of missing them. So you got to make sure until we figure out how Dexcom's going to truly address this. That's number one, right? I'm sure they're shocked. We're shocked. I mean, I've never even heard of something this crazy. But hopefully they're going to decide how to get this message out. It can't just be here's the lot numbers, because most of our patients aren't looking online. They're not following, you know, you and I or anyone else for that matter about diabetes, and they have no idea it's happening. So we want to make sure it's the attention is given to the patient as quickly as possible. Hopefully they'll do something similar.
Right. Yes, that is definitely the hope. All right. And then other topic that we just want to discuss is retatrutide has been in the news again with some new top line data from the Triumph trial. So retatrutide is a triple agonist. So right now we have single agonist, we have one dual agonist, tirzepatide, and this is the first triple with GLP-1, GIP, and now glucagon. So, Natalie, you want to share what this exciting data is?
Yeah, I mean it really is. You guys, this is big news. Population was adults with obesity or overweight. So number one, realize these people didn't have what? Diabetes. Remember, when people have diabetes and we use GLP, GIP, and even triple agonists, we're probably going to see, we don't know for sure yet because the data is not out, but we tend to see, we definitely see less weight loss. But this is for overweight and obese, one related comorbidity. So that would be hypertension, hyperlipidemia, something else is going on, right? But no diabetes. 80 weeks was the primary endpoint, 104 weeks was the extension. So this is a Lilly drug, right? Lilly looked at that and said, let's follow them for a long time. Let's look and see what we can do, because this is a lifelong illness. Obesity is a lifelong illness, just like diabetes is, right? So duration 80 weeks and then 104 weeks in the extension. All doses were tested: 4 milligrams, 9 milligrams, 12 milligrams. This is easy, you guys. There's only three doses. I'm super excited about that already, right? All doses met primary and key secondary endpoints, right? I just want you to know that, right? So average weight loss, are you ready? 70.3 pounds. This is
That's so
incredible.
much. That is so
70.3
much.
pounds, 28.3% of body weight. 45.3% of participants hit greater than or equal to 30% weight loss, which is where bariatric surgery plays a role, right? So this is a rate really getting close to that bariatric surgery data.
Mhm.
And then extension data at 104 weeks with the baseline BMI of greater than or equal to 35, the average weight loss was 85 pounds, which is a 30.3% weight loss. and it did not plateau. So at 104 weeks, you guys, they were still losing. They just said, all right, we got to publish this. We got to draw a line someplace. So I'm super excited about the extension because maybe we'll see more, right? The lower dose, 4 milligram arm, they lost 19% body weight. So the first dose is 19%. And the discontinuation rate, ready for this, is lower than placebo. So that to me says a lot that I could put someone on the lower dose and have them discontinue less than placebo. This is big, big, big news because why do we have discontinuation rates? GI, all kinds of stuff, right? But they had less than the placebo group. This is amazing. So what's next? We're going to have that was Triumph 1. That's the big announcement. What are we waiting for now? Triumph 2, obesity and type 2 diabetes. Triumph 3, obesity and established CVD disease, because we got to make sure if we're losing weight, if we're helping, we got to make sure that every single molecule that we're prescribing is going to give us the same cardiovascular benefit that we see in the once weeklies we're using now, right? And those established CVD disease are going to come later this year. And then we're expecting full Triumph 1 data at ABA next week where we will be. So super excited about that, right? Super excited. So, Diana, how do you feel?
Well, I'm very excited to hear the full readout, and hopefully we'll also see a publication around ADA as well. I think this now showcases the positive data in both obesity and in type 2 diabetes that they previously had reported out from Transcend. And this very much is in line with bariatric surgery. And I have patients that are hearing about this top line data. It's in the news, it's all over. And some of them are saying, they've been referred to bariatric surgery, but they're like, I want to wait. I want to see that these drugs come out, because a lot of people would rather take medication than go through a surgery. I had someone today that was like, I can't just take off of work for a surgery. Like, I don't have time for that. So the idea of being able to have medication management over a surgery is very desirable for a lot of people. So this is really like, this is ushering in a new era, and it is incredibly exciting. And it kind of makes me wonder, like, right now, like, what's going to happen? Like semaglutide, tirzepatide are such powerhouses right now, but like, we are entering in this new era, and this is probably going to be the first of many. There are other
Yeah.
companies that are also working on triple agonists, and this is the direction that we're going. It's very exciting.
Incredible, incredible news. Wow, what an amazing week, the week before ADA. There's a lot going
Yes.
on before we even get there.
So much going on. So we thank you very much for tuning in. We will have many more episodes coming up very soon with ADA. But as for now, that wraps up this episode of Diabetes Dialogue, Technology, Therapeutics, and Real World Perspectives.
Thanks, everyone.